I want to start with a number that, honestly, it just completely threw me when I was going through our source material.
Oh, yeah.
Yeah. If you go to a doctor right now and they just feel your neck, a physical exam, they might find a thyroid nodule in maybe, 5% of women.
And even less in men, maybe 1%?
Exactly. It seems super rare.
It does. If you stop right there, you'd think, okay, this isn't really a widespread issue.
But, and this is the part that got me, if you take a totally random group of people, healthy, no symptoms, and you do a high-resolution ultrasound, you suddenly find nodules in up to 68% of them. 68%.
It's a staggering difference. It's a completely different reality.
It's more than staggering. It's almost a little scary. It means that, more than half of us could be walking around with these things and have no clue.
And that gap, that huge discrepancy, is precisely why these guidelines we're looking at today exist.
Right, this is the 2015 American Thyroid Association Management Guidelines.
And they were written to tackle this exact problem, what some people call an epidemic of diagnosis.
I saw that phrase. It sounds like a contradiction, doesn't it? An epidemic of diagnosis.
It does.
I mean, you'd think more diagnosis is a good thing. But the numbers tell this really strange story. From 1975 to 2009, thyroid cancer diagnoses tripled.
Tripled.
But the mortality rate, the number of people actually dying from it.
Barely, bud. It stayed almost flat.
So we just got better at finding tiny, tiny cancers, these small papillary thyroid cancers, that were probably never going to be a threat.
Exactly. We found them, and so we treated them, often very aggressively. Which leads us to the mission of these guidelines and, our mission for this deep dive.
How do we stop? How do we move away from that see a lump, cut it out mentality to something smarter?
It's all about risk stratified care. Or, the way I see it, it's about being a detective, not a surgeon by default. We have to figure out which nodules are the real villains.
And which are just bystanders.
Right, because treating the bystanders has real consequences.
Okay, let's do it. Let's play detective. So a nodule is found. My first instinct as a patient is, get a needle in there. I need to know.
And that's everyone's instinct. But the guidelines say, wait, hold on.
Put the needle down.
Put the needle down. The very first step is actually just a blood test, a TSH level.
Thyroid stimulating hormone.
Right. We're looking to see if the thyroid is working too hard or not hard enough. Specifically, we're looking for a low TSH.
Which means the thyroid is overactive, hyperthyroidism.
Yes, and while that can be its own problem for your health, in the world of thyroid cancer, a low TSH is, believe it or not, the best news you can get.
How so?
It's just the nodule itself is the thing pumping out all that extra hormone. We call it a hot nodule.
And hot nodules are almost never cancerous.
Almost never. Malignant cells are usually dysfunctional. They don't do their job of making hormone. So if you find a low TSH, you do a radionuclide scan. If that nodule lights up,
It's hot.
it's hot. And you're done with the cancer workup. No biopsy needed.
That's a huge off-ramp. You've just saved someone a lot of anxiety with a simple blood test.
A massive off-ramp.
But okay, let's say the TSH is normal. Or maybe it's high. The nodule isn't high.
Now we have to look at it. Now we turn to the ultrasound.
And this is where the detective work really kicks in. It's not just about size anymore.
No, the old way was, it's over 2 centimeters. Let's biopsy. Now we look at its character. It's a fingerprint.
So you're profiling the tumor.
We are absolutely profiling it. We're looking for high-risk features versus benign ones.
Okay, so walk me through the most wanted list. What on an ultrasound screen screams cancer?
Well, there are a few key things. First, something called microcalcifications.
Tiny white specks, like little grains of sand.
Exactly like that. That's a very bad sign. Second, the shade. Is it darker than the surrounding thyroid tissue? We call that hypoechoic.
Darker is more suspicious.
Darker is more dense with cells, so yes, more suspicious. Then the borders. Are they smooth and clean, or are they jagged and irregular?
Like it's trying to invade the tissue around it.
Precisely. But the number one giveaway, the one the guidelines really emphasize, is the shape.
This is the taller than wide thing.
That's it.
I have to admit, that sounds so specific. Why does that matter so much?
Think of the anatomy of the neck. Tissues have layers, planes that run horizontally. A benign growth will usually just push things aside and grow along that path of least resistance. It gets wider.
Okay.
But something that's growing taller than wide is actively pushing against those natural boundaries. It doesn't respect the anatomy.
It's aggressive. It's forcing its way through.
It's a sign of invasive potential, exactly. So if you see all of that dark microcalcifications taller than wide today, your cancer risk is north of 70, maybe even 90%.
Wow. Okay, so that's a definite biopsy. What's the opposite? What does a friendly, don't worry about me nodule look like?
A sponge.
A sponge. We call it spongiform. It's mostly cystic, like a honeycomb. If you see that pattern, the risk of cancer is tiny, less than 1%.
So this is where the rubber really meets the road, right? How these patterns change the size rules for biopsies. This is risk stratification in action. If you have that high suspicion villain pattern,
Dark, tall one.
yep, we biopsy that at 1 centimeter. We don't wait.
And if it's a low suspicion pattern.
We wait until it's bigger, maybe 1.5 centimeters. And for that spongiform nodule, the really benign looking one,
Yeah.
the guidelines say you can wait until 2 centimeters or even just watch it. Maybe don't biopsy it at all.
That's the whole shift right there. We are actively choosing not to know about certain small nodules.
Because knowing doesn't help the patient. It just leads to more tests, more anxiety, and surgeries that were never needed.
All right, so let's say we do the biopsy. We've crossed the threshold. Now we get to what, for me, is the most frustrating part of this whole field, the gray zone.
Ah, yes, the indeterminate result.
You get the report back, and instead of saying benign or malignant, it says something like atypia of undetermined significance,
AUSFLUS. It happens in up to 30% of biopsies.
which basically means we don't know. That must drive patients crazy.
It's limbo. The pathologist is saying, the cells look a little weird, but not weird enough for me to call it cancer. They're stuck.
So in the old days, what happened then?
We operated. We do what's called a diagnostic lobectomy, take out half the thyroid just to get the answer.
That's a major surgery just for a diagnosis?
It was the only way. But this is where technology has been a game changer. The guidelines are now huge on molecular testing.
Analyzing the DNA from the biopsy sample itself.
Exactly. We're looking for the genetic mutations that drive cancer. And you can think of it in 2 ways. Rule-in tests and rule-out tests.
Okay, explain that distinction.
A rule-in test looks for a smoking gun. The classic one is a mutation called BRFA600E.
Right.
If your nodule has that BRF mutation, there's a greater than 95% chance it's a papillary cancer. If you ruled in the diagnosis, you can plan for the right surgery.
So it turns a gray into a definite black. What about rule out?
That's the other side of the coin. That's for when you really hope it's benign. You use a different kind of test, a gene expression classifier. It looks at a whole pattern of genes.
And if it comes back negative?
It gives you a very, very high confidence that the nodule is benign. You've ruled out cancer. And you've just saved that patient from an unnecessary surgery.
That's incredible. So let's follow that path. Let's say we do need surgery. The biopsy was malignant, or the molecular test confirmed it. This part of the guidelines felt like the biggest philosophical change, the surgical shift.
It was a massive pendulum swing, for sure.
The old way was total thyroidectomy. Cancer means the whole thyroid comes out. No questions asked.
Take it all out, clean sweep. It felt safer, more definitive.
But the 2015 guidelines really pushed back on that.
They did. They said that for most common thyroid cancers, papillary and follicular, they're between 1 and 4 centimeters and haven't spread.
Yeah.
A lobectomy is enough. Just take out the half of the tumor.
Okay, I have to play devil's advocate. If I'm a patient and you tell me I have cancer, my first thought is, get it all out. Why leave half an organ that just proved it can grow cancer?
And that's the perfectly normal, intuitive fear. But the data just doesn't support that fear. When they looked at huge groups of patients, the survival rate was the same.
You live just as long with half a thyroid as with no thyroid.
Exactly. You live just as long. But your quality of life can be significantly better with a lobectomy.
How so? What's the downside of taking it all out?
Two big things. One, you are guaranteed to be on thyroid hormone pills for the rest of your life. With a lobectomy, that remaining half might just be enough.
So you could avoid lifelong medication.
You might. And second, the complications. Behind your thyroid are these tiny parathyroid glands that control your calcium, and the nerves to your voice box run right there.
So operating on both sides of the neck doubles your risk of injuring one of those things.
It doubles the risk. With a lobectomy, the other side is untouched and safe. So survival is the same. Why take on that extra risk?
That makes perfect sense. But there's a step that's even less invasive than a lobectomy. The one that really blows my mind.
Active surveillance.
Doing nothing. Just watching.
The ultimate less is more approach. This is for papillary microcarcinomas.
Cancer smaller than 1 centimeter?
Yes. We used to find these incidentally and immediately scheduled surgery, but a team in Japan, Dr. Ito's group, started asking, well, what if we just watched them?
And what happened?
Almost nothing. The vast majority of them never grew, or they grew so slowly it didn't matter. They almost never spread.
So the word cancer in that context is almost a bit of a misnomer, behaviorally speaking.
It behaves more like a benign mole than what we think of as cancer. So the guidelines now say if it's not in a dangerous spot, like right on the windpipe,
You can just watch it.
you can safely just monitor it with ultrasound.
That requires a huge mental shift from the patient, though.
It's the biggest hurdle. You have to be okay with knowing there's a cancer in your body and choosing to leave it there. Not everyone can do that.
No, I can see that. Some people just want the peace of mind of having it out.
And that's a valid choice. But for the right person, it avoids a surgery they absolutely do not need.
Okay, so let's shift to post-op. Surgery's done, now you're in follow-up. And there's this distinction that I think confuses everyone. Staging versus risk stratification.
Oh, it confuses doctors too. It's a constant source of misunderstanding.
So break it down for us.
Okay, TNM, staging stage 1, stage 2, and so on, is designed to predict one thing: mortality. It answers the question, am I going to die from this?
And with thyroid cancer, the answer is usually.
Almost always no. Most patients, even with spread to lymph nodes, are stage 1. Their survival is nearly 100%.
So they hear stage 1 and they think, great, I'm cured.
Right. But then the doctor starts talking about being intermediate risk or high risk. That is ATA risk stratification. And that predicts something different. It predicts recurrence.
Is it going to come back?
Exactly. So you can be stage 1, you're going to live, but still be high risk for the cancer coming back somewhere.
And that difference dictates the next step in treatment.
It dictates whether or not you need radioactive iodine, RAI.
The magic bullet. You swallow a pill, and it zaps any remaining thyroid cells
Yep, it's a very targeted therapy. But the theme here, again, is de-escalation. We used to give it to almost everyone.
to mop up the leftovers.
Right, remnant ablation. But the 2015 guidelines say, for low-risk patients, do not routinely give it.
Why not? If it kills any stray cells, what's the harm?
Because it's not harmless. It's radiation. It can damage your salivary glands, cause permanent dry mouth, and it carries a small but real long-term risk of secondary cancer.
So if your risk of recurrence is already, say, 1%, it doesn't make sense to take on those other risks.
The math doesn't add up, the benefit doesn't outweigh the harm. Now, for high-risk patients, absolutely, we still need it. But for the low-risk majority, we're skipping it.
Okay, so surgery's done, maybe no iodine. How do you keep an eye on people for the long haul?
Two main tools, a blood test and an ultrasound. The blood test is for a protein called thyroglobulin, or T.
Which is only made by thyroid cells.
Only by thyroid cells. So if you've had a total thyroidectomy, your T should be 0. Undetectable.
And if it's not 0, or if it starts to rise,
That's your smoke signal. It tells you there are thyroid cancer cells growing somewhere, often months or years before a scan could see anything.
and the other tool is just checking the neck.
Our old friend, the ultrasound, making sure no suspicious lymph nodes pop up.
I do want to quickly touch on one group, pregnant women. Finding a lump during pregnancy must be absolutely terrifying.
It is. But the guidelines here are very reassuring. You can do the ultrasound safely. You can even do the biopsy. The only absolute no-no is anything radioactive.
No radioactive scans or treatment.
Right, that can harm the fetus.
And what about the surgery itself? Is it an emergency?
Almost never. This cancer grows so slowly that in most cases you can safely wait until after the baby is delivered to have the surgery. It doesn't change the outcome.
That's a huge relief to hear.
It is.
So if we pull all of this together, from the initial scan to the surgery to the follow-up, what's the one big idea, the through line here?
It's that pendulum swing. We were in a search and destroy era for decades. Find it, cut it out, radiate it.
We treated the scan.
We treated the scan. Now we're in an assess and manage era. We're treating the biology of the tumor. We're realizing that cancer isn't one thing, and the treatment shouldn't be one size fits all.
It also feels like it puts more power in the hands of the patient.
It does. It empowers you to ask questions. To ask, what are my sonographic features? Or is active surveillance an option for me? Or why do I need a total thyroidectomy and not just a lobectomy?
You can have a real conversation about the pros and cons instead of just accepting the most aggressive path.
Yes. In this disease, less is very often more. Same survival, better quality of life.
You know, the thought I want to leave everyone with is something that just kept hitting me. Our technology is so good now. We can see these millimeter-sized imperfections in our bodies.
We have medical superpowers.
We do. But the hardest part of medicine today isn't figuring out how to fix something we find. The hardest decision is learning when it's better to do nothing at all.
That is the entire paradox of modern medicine. Just because we can find it doesn't mean it's a problem that needs fixing.
And are we, as a society, as patients, ready to accept that? To live with known abnormalities instead of trying to achieve some kind of perfect, clean scan? That's really the challenge these guidelines pose.
It's a profound shift in thinking, but it's a much healthier one in the long run.
Thanks for breaking all that down.
My pleasure.
We'll catch you on the next deep dive.